The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. Thank you for those viewing for your interest in this topic of TMD Demystified. I am Tony Urbanek. It is another Tuesday, and we are here to talk about the topic of the day, which is entitled TMD, TMJ, and OSA. As I remind you on many of these episodes, I also do a daily blog, a written blog, which is directed to patients rather than providers. And that blog is published on our website on a weekly basis and other places. It's disseminated widely. But I try to keep the topics similar between the written blog and the videotaped podcast for simplicity for me, so that I can just prepare one topic rather than two topics a week. And I found it over a period of time very expeditious for the purpose of comparing and contrasting what I need to say between a patient population and a provider population, a dental population. And that particular issue stands out vividly when it comes to this week's topic, because the blog was entitled TMD, TMJ, and OSA, Why All the Confusion. And I intentionally used the acronyms to gain the patient's attention, because not everyone knows what OSA is. Most of patients know what TMJ is, as you know. But there are distinct differences between the two, and there is what I have found out, almost total confusion among certainly patients. That is a given, but tremendous amounts of confusion between these two diseases among dentists. Now, this first came to light in my experience over a year and a half ago, when I was on the telephone with a younger dentist in another state who was interested in what I had to say or teach and what she could learn about TMD. And within a couple minutes, she began talking and expressing her opinion and current knowledge, and it became obvious to me that she was conflating TMJ disease with obstructive sleep apnea. And as I finished the conversation, and I didn't make a big deal out of it, I didn't necessarily correct her. I gave her the information she needed. I think I did make a comment, a brief comment about whatever her immediate comment was, that was just off the wall as far as confusing OSA, and that the two devices are totally different. But as I went on, I began to see that this is common in the dental arena, and that especially younger dentists and the very old dentists have combination of no interest in either device or disease. And the middle-aged dentists, I think, have been out there long enough to be exposed to the general nature of what's in the common media, the public media, rather than the dental media regarding what's available between treatments for TMD and TMD and OSA, obstructive sleep apnea. It surprised me terribly. So that's why I am doing this particular episode to my dental colleagues to try to straighten this out in a very specific way. Obviously, I would think that the majority of the dentists who have been in practice for 5 to 10 to 15 years have the general knowledge that OSA and TMD are not the same disease. But the first point is that I have seen directly, even by well educated dentists and dental instructors and dental professors in dental schools, that they have confusions about the relationship between TMD and OSA. And we'll get into that in just a minute. So let's just define our terms. First of all, TMD is a disease that affects the temporomandibular joint with chronic inflammation. Chronic inflammation drives all the symptoms of headache, earache, jaw pain, neck pain, ringing, fullness, dizziness, upper back, shoulder pain, arm, hand, finger tingling, and numbness, and various kinds of jaw locking. And OSA, obstructive sleep apnea, has the primary symptoms of persistent snoring, excessive daytime fatigue, poor concentration, sleepiness during routine activities, early morning headache, depression and irritability, restless sleep, witnessed pauses in breathing, choking or gasping for air during sleep, and frequent visits to the bathroom are the most common symptoms of obstructive sleep apnea. And sleep apnea is caused by collapse of the pharyngeal airway behind the tongue. Very briefly, the airway behind the tongue is not a round tube, it's a flattened tube. And in a healthy person without sleep apnea, the tube is wide enough so that when they go to sleep and all the muscles relax, the tube doesn't constrict because the muscles relax, but the tube, the diameter of the tube, the volume of the tube decreases, but there's still enough room to move air up and down. But in a patient with sleep apnea, the tube is narrow enough now so that when the muscles relax, the tube totally collapses on itself, and until they wake up, they're not going to move any air up and down. That is the simplistic but accurate definition of the cause of sleep apnea. There are a few variations. There's central sleep apnea having to do with the brain and the brain stem, but vast majority, 95, 98% of patients with obstructive sleep apnea is actually obstruction of that flattened tube, which is located behind the tongue. And the treatment for sleep apnea, the most effective treatment for sleep apnea is CPAP, basically a mask and a engine that blows air through the nostrils or the mouth and actually inflates the lungs for the patient while they're sleeping. And then the second line of defense is an oral device, which pulls the mandible forward, literally puts traction on the mandible and pulls it forward, pulling the tongue forward and therefore increasing the volume or diameter of that flattened tube behind the tongue. That is basically a description of the two diseases and what is the primary cause. In the case of temporomandibular joint disorder. The cause is damage to the joint one way or another, either through chronic bruxism, acute trauma, or functional malocclusion. Basically, they're all traumatic events, acute or chronic traumatic events, which damage the joint, which creates chronic inflammation. Chronic inflammation does not dissipate or go on to healing, but continues to be there, which then sends autonomic nervous systems to all the muscles that says tighten up. And that is why TMD and tennis elbow is actually the same phenomenon. It is the same phenomenon. It's the same disease, actually, just different joints. And obstructive sleep apnea is a disease. Primarily, it's a physical phenomenon. As we grow older, our necks get thicker and our muscles get more flaccid, and we gain weight. And as that happens, it tends to constrict or put pressure on that posterior tube behind the tongue, and it's not as wide as it was before. It's more narrow, and then patients develop sleep apnea. Sleep apnea is seen more often in males, roughly 2/3 male, 1/3 female, and TMD is the opposite. TMD is seen primarily in females, literally 90% females, 10% males, and it is primarily most prevalent in females because of this one fact, which is estrogen exacerbates inflammation, chronic inflammation. So that is the technical difference between the two diseases. And those two diseases can occur simultaneously, but they are not the same disease. They have really no relationship in the cause of the disease. And as I will speak on in a minute, they are not related in one causing the other. Now, I've had intentionally or unintentionally had discussions with certain university professors who wanted to take me to task because I was adamant that the two diseases are not related. They are separate diseases. They have separate causes. They have separate pathophysiology. But there is a movement afoot out there, and it's in gaining traction and draining volume and visibility, that bruxism actually exacerbates or causes, in one way or another, OSA, and/or that OSA, obstructive sleep apnea, will exacerbate or cause bruxism. So regarding that effect, I did some research, and this is the Bible for sleep medicine. Krieger, Roth, and Dement. This is the 2017 edition of Principles and Practice of Sleep Medicine, 6th edition. And it goes over very thoroughly. Most of the authors in this, literally, I think it's about a 20-pound textbook, are mostly MD, PhDs, pulmonologists, but they have a scattering of sections and articles on I'll read some of them. The role of dentistry and otolaryngology in sleep medicine, sleep bruxism, diagnostic considerations, orofacial pain and temporomandibular joint disorders in relation to sleep disorder, breathing, and sleep bruxism. That is the primary area of this text that I want to quote, and I'm going to quote Dr. Gregory Essex, who's a DDS PhD, who monitored the information, monitored the articles and the papers regarding research, some of it good, some of it not, but monitored all the articles and posted his results in this textbook regarding this issue of does OSA create or exacerbates one way or another TMD, and or does TMD create or exacerbate OSA? And in a word, his statement was that it doesn't. Now, there's a confusion. Here's the confusion. You can have, no doubt about it, you can have concomitant, excuse me, position or experience both diseases at the same time. You can have sleep apnea and TMD at the same time. Actually, in our practice that we see, roughly 15 to 20 new TMD patients per week, consultations per week. I would say that probably once a month, twice a month, we run across patients who have both OSA and TMD. So they can happen concomitantly, but because they happen simultaneously in the same patient does not mean they're related or that there's a cause between the two. That this, concomitant does not equate to cause and effect. So that is the first point. Now, what I want to take just a minute explaining, though, on really clinically why this is a problem, and then I'll just speak briefly on what you need to do about it, what you can do about it, and what you can't do about it. So here's the simplicity of the situation. It's really a mechanical issue. And excuse me, but let me use my hand diagrams. TMD, temporomandibular joint disorder, is a disorder of the glenoid fossa, the socket, and the condyle, and the disc in between. And that disc becomes damaged and creates inflammation within the joint, chronic inflammation. The proper treatment, the non-surgical treatment using a very, very effective device, which separates the back teeth, simply allows the condyle to go back to centric relation, whatever its most comfortable centric relation is, which is better known in the textbooks as the rest position. That's the rest position, centric relation, which when you unload the joint simultaneously by separating the back teeth, you unload the joint like a set of crutches, unloads the knee, and you use it according to a protocol, starting out 24/7 for 2 months, and then nighttime the rest of your life. What you're actually doing is unloading the joint and allowing the condyle to go back to rest position, central relation. And using that combination of device and protocol will decrease symptoms into the 95% range in 95 or more percent of the patients who follow the protocol. The problem is a few patients won't follow the protocol and don't get the result or don't get enough result. They get result, but not in the 90% range. But that is TMD. Sleep apnea, on the other hand, we discussed what the problem is, but the solution with the sleep apnea device is to put traction on the mandible and pull it forward, increasing the airway in the back of the tongue. works really well. In fact, my observation, consistent with the other statistical observations in the literature, shows anywhere between 75 and 85% success rate, meaning obstructive sleep apnea, mild, moderate, and even severe, will decrease its symptomatic problem, or in other words, increase your relief of the symptoms 85%, 85%, which is huge. It's not 100% like CPAP. CPAP is 100% effective as long as you wear and use CPAP. The problem is nobody wants to use CPAP. I mean, almost nobody wants to use CPAP, and the pulmonologists have given up really expecting patients to use CPAP and falling back to referring out larger and larger numbers of patients for oral devices. They feel that it's much better to refer a patient for oral devices that give a 75 to 85% success rate, and they will use it rather than referring a patient and recommending CPAP, where 90% plus of the patients eventually end up not using it. Now, with the oral device pulling the mandible forward and bringing the tongue forward and increasing the posterior airway, you simultaneously pull the condyle out of the glenoid fossa. And that is not physiologic. And over a period of time, that can create on its own chronic damage to the joint, and chronic inflammation. And as I already discussed, chronic inflammation is the chief consistent cause of all the symptoms in the joint. So, and it is well established. It's ensconced in many of the scientific articles about OSA, that an OSA oral device putting traction on the mandible can create TMD symptoms. Definitely known. So again, a TMD device allows the mandible to go back to proper centric relation, rest position, symptoms diminish of TMD. OSA, the device puts traction on the mandible, distracts the condyle from the glenoid fossa, eventually creating damage within the joint, chronic inflammation, and literally creating TMD where there was no TMD. So, you know, you can cause TMD by using a sleep device, for sure. But bruxism does not create OSA, as stated very clearly by Dr. Gregory Essex in his chapter entitled Orofacial Pain and Temporomandibular Joint Disorders in Relationship to Sleep Disordered Breathing and Sleep Bruxism. So you can brux at night, for sure. You can have OSA at night, for sure, but there's no cause and effect here. All right, with that said, I hope I've made my point. You can research it out for yourself. And in fact, I recommend you do that. Don't take my word for it. I do have a lot of experience in this area. I'm seeing the patients. And by the way, I didn't cover, but need to cover. So what do you do when you have two patients? You're really stuck, as they say in Tennessee, between a rock and a hard place. You have patients who really want to wear a sleep device, but it causes symptoms. It could be just pain in the joint, which can occur, pain in the joint itself, but pain in the joint leading to jaw pain, muscle pain, neck pain, shoulder pain, ringing, fullness, dizziness. What do you do? Well, it's a difficult thing. First of all, what I tell the patients, this is clinical experience, it's like, which disease is most important to you? Which disease gives you the most problem in your life? Is it the pain and symptoms of TMD, or is it the symptoms of obstructive sleep apnea. And hopefully and the patients I've had consultations with, they give me one or the other, at which point then I lead them to what is most likely the best solution. If TMD ends up their most egregious set of symptoms, then I tell them that they really need to take a second look at the CPAP machine, which gives them 100% resolution of their obstructive sleep apnea. If their obstructive sleep apnea is most important to them, then I may recommend, and I can't claim how effective it is because of the few number of patients I've recommended it to and gotten responses, but using the sleep OSA device at night and the TMD device during the day. And I have had some patients who have had good results with that, because if you allow during the day the mandible to go back to rest position and you unload the joint enough, theoretically you can hold the chronic inflammation down to a level where it doesn't tip over and create symptoms. I hope I've made that clear. I hope I didn't confuse you by saying that. But those are the two methods when patients have concomitant experience with both diseases at the same time. Unfortunately, they're few in number. They're not the majority by any means, but certainly I have seen it a couple times a month. So in one case, if TMD is their primary complaint, that's their primary complaint, and they need to wear that TMD device at night, then I tell them to take a second look at the CPAP. And if OSA is what is ruining their life the most, then I suggest in some patients to wear the OSA traction device at night and try to use the TMD device during the day. And in some cases, that has been effective. Thank you for your attention. I hope this is meaningful, meant something to you. I hope you learned something. I do recommend you do your own research. I recommend that you learn by treating patients with both devices. I recommend highly that all dentists, young and old and middle age, use both an OSA device and a TMD device in your practice. It's becoming more common. I think there's a move afoot, definitely, to integrate medicine and dentistry for sure. You're going to hear a lot more about that. And I think it is a wonderful service for the patient and a wonderful service to some doctors who want to get out from the aspects of medicine being bent over a patient eight or more hours a day, when you can treat a large number of patients who have very, very significant needs by using oral devices, whether they be OSA device, TMD device, or now every dental provider in the United States wants to do aligners. And I think that there's a increasing number of dental practices that are going to do those three procedures, and just those three procedures, on a routine basis. I think you'll see a lot more of that in the dental industry. Thanks for your attention. If you'd like to contact me, I'm available at tony@tmjservices.net. If you'd like to learn more about the Urbanic device and protocol and how it actually solves non-surgically the TMD problem using our independent university study validated device, FDA cleared and patented device, you can learn more and get in contact with us and actually take an online course at www.urbanictmj.com. Until next time, I look forward to the opportunity to visit with you again and hopefully enlighten you on TMD Demystified. I am Tony Urbanic.